Happy birthday. Thank you. Guys, today is my birthday. So we're going to keep it light. I want you guys to go in the chat box. I turned 34 today. Tell me if it's all uphill or downhill from here. Take your time to think about it. Be honest. So guys, welcome. Today is the final webinar number 12 on concussion management. Alex, can you talk a little bit about what we've been up to during the quarantine to sort of upgrade ourselves, the clinic, so on and so forth with the concussion stuff?
Yeah, totally. So basically, we've been taking a course called Complete Concussion Management, and essentially, what Complete Concussion Management is, it's basically a way of educating healthcare professionals, a lot of them physios and chiros, and how to manage concussions initially from day one. So it gives you basically a very streamlined and structured way to approach treating concussions. But not only that, also people have persistent symptoms. It gives you a lot of detail and resources and ideas on how to manage them. They have really helpful things as well, technologies such as apps that can be very useful for people who get concussions, and also communicating with coaches. So it's really popular in sports right now as well. But I think the biggest thing that it does that it just kind of gets a uniform format in dealing with concussions. And there's really kind of poor concussion management noted in the literature. Often with even medical students in like 2015, only like 30% had like concussion material in their actual education. Now with more and more education, as we learn more about it, there's like 90%. So they're really just trying to do their part and get everyone used to doing a really good job treating concussions. And I think they do that. It's basically my 5th concussion course, and I found it to be the most thorough, the most supportive, and really does an excellent job at giving you the exact details, the most recent research. And so I can't speak highly enough of it right now.
Awesome. So before we carry on, and we're going to talk about a whole bunch of stuff, we're going to talk about what a concussion is, what it looks like after you've had one, and then some rehab strategies to get back to full function. Just a quick disclaimer, everything's going to be light after this, but on a serious note, we're going to spend 30 minutes talking about this great subject. I don't want people out there, whether it's on this webinar right now or on YouTube later, to use this as an alternative to seeking information from a physician or a physiotherapist. So I don't want you to, if we're giving out some treatment strategies, I don't want to, if you're concussed or you know someone who's concussed, you send them this link, try the things that they're doing here. No, go see a health professional. Obviously, it's a very serious injury. So we're going to jump right into it. We're going to talk about what a concussion is. So first of all, like the older theory was a coup counter coup, meaning like you hit your head and envision my little brain in my head that just bounces on one side of the skull and rebounds and bounces on the other one. That was the old theory. The newer theory is, and then you were left with a brain bruise. That was kind of the old theory. And then the newer theory is that the same thing happens. You hit your head, and then envision your brain being like jello. And within your head, this kind of happens. Brain stretches out this way and then catches up and then goes back this way. Or there's rotary forces that happen. So it goes like this and it catches up. So you end up getting deformation or a temporary stretching of the brain. And that's what a concussion is. There's also the rotary forces, like the brain's up here, there's a brain stem, and that's where there's some torsion. And the brainstem is where the vestibular system is, which we're going to touch on later. So that all gets affected. So I'm going to share my screen and I'm going to share a drawing with you guys and I'm going to add to it. Just give me a sec, guys. And then Alex, you can let me know if you see this picture.
Yep, I sure do.
Now, for everyone who's looking at this picture, wondering, who's the 4-year-old that drew this last night at 10 p.m.? I'm deeply offended. So this is, hold on one sec, I got to move things around a little bit. So at the very top, we're starting up here, okay? Let's look at that as being a nerve cell. Not the best representation based on my art skills, but that's a nerve cell. There's the cell body here, and then there's the axon over here, and then you get axon terminals, and then you have other neurons. So in the brain, whenever you have, let's say, a thought, or you're about to do a movement, or anything that requires brain activity, there's a signal that gets sent in from a neuron prior to this one, and then you have channels throughout this axon. You have a bunch of molecules that live on the outside of the cell, and you have a bunch of molecules that live on the inside. So when you get a signal, what happens is these channels open, these molecules from the outside rush into the cell, and the molecules from the inside, they rush out. And then the signal gets passed along to these neighboring molecules so that your entire brain can communicate. When you have a concussion, when you have that deformation or that stretching, what happens is that these channels, let's call them now, we'll call them floodgates, they open up from that stretching that happens. So like I just described, now it's like they're coming in way more, they're leaving way more, and you get this state of like hyper-excitation. So your brain has been tricked into thinking that everything needs to be turned on all at once. And that's what leads to this basically this energy storm here that you guys see here. This is where things start. Now I made a graph to make this a little bit easier. So on this side here, you have ATP. That's our energy molecule required for all the stuff that happens up here. Down here is time. So let's assume you got a concussion. You have this crazy electrical storm that's happening right here. So what happens, like in this phase right here that I'm circling over and over again, if you ever watched in hockey someone take a big hit, and then they're in center ice, and because I've delivered this hit a few times, but like what happens is the person will fall down, and you'll see them on their way to the bench kind of stumble, like they can't get their footing. That's just that very brief from this timeline here where you can't even get your bearing straight. It doesn't last long, but what happens following a concussion for the next 5 to 7 days is that your energy levels plummet down. So if you've ever known or you've ever been concussed, you'll notice that during this section right here, that's where that's where we recommend mild rest or mild activity, if not any, because that's where people want to sleep, they're fatigued, they're irritable. This is where things are at the very worst, the first few days here. And then at day 5 to 7, which is usually about the worst, you start to turn a corner and you start to work your way back up. And then hopefully you'll rate your way right back up to baseline, which is right here. And this usually happens in somewhere around 22 to 45 days, depending on what research you're looking at. Now, what's important to know is that a lot of people, let's say you're a young hockey player, you're 18 years old, we're now at day 10. So we're right about here, let's say. Okay? At day 10, oftentimes people start to feel asymptomatic, meaning the headaches are gone, the brain fatigue is gone, the irritability is gone. They're like, hey, coach, I feel great. I'm ready to go. So what happens is on, let's say, day 10, they have a game, they go back to play, they get another concussion. The problem with that, because they did not reach officially their baseline here, is that this is going to start to go down again. But now we're in like no man's land here. We don't want to go down here because now the recovery might not be 22 to 45. It might be closer from 90 to 120, give or take. So now it's just the amount of work it takes to get back up is going to take way longer. And God forbid he goes back and gets another one down here. Now we're looking at like persistent concussion symptoms, right? So it gets harder and harder to rehab. Now, I just gave you an example of reoccurring and the additive effect of concussions. The other scenario is that the person plummets down, starts to recover, but never reaches baseline. They just never get to that right here. They never reach it. There's about 30% of people that don't reach that because they have one of 5 issues. It could be a blood flow issue. It could be a vestibular visual issue that Alex is going to talk about. It could be a neck issue that I'm going to talk about. It could be psychological, not really my role, but whether they need to see a psychologist or cognitive behavioral therapy. Or the last one is like it could be an inflammatory, metabolic, or even a hormonal issue. And that's preventing them from getting to the top. So what I wanted to hit home with is our role when it comes to concussion. There's 3. There's filling up the gap right here. So someone gets concussed, They report to their coach, I feel amazing, I want to go back. Well, go see a therapist and see. And we're going to check your eyes, your neck. We'll evaluate your whole body, and we'll determine whether or not we think it's safe. That's our rule number one. Okay, so it's like it's clearing people to play to make sure they're safe to go back, so they don't end up doing this stuff, right? Number two is rehabbing these people that have had an additive effect. They need more therapy. They're going to need more of the 5 things that I just talked about. And the last one is the 30% that don't achieve their baseline, is they need some assistance from a therapist to find which systems are affected and how we can get them better. So that's all. This is basically how concussions work and how our roles are integrated to help people out. Alice, can you dive into vestibular visual stuff? Hold on.
For sure.
I'm just gonna unshare my screen there. Hold on. I have to
Okay.
put my tablet down for that. What a drawing, by the way. What art.
And you can make me the host as well.
Oh yeah. Okay, hold on. Okay, you're the host.
Okay, cool. So let's see if I can share my screen now. Awesome. Share, let's share that. Okay, cool. So I really like this diagram because it kind of puts everything all together. It shows that, you know, your visual system, your vestibular system, your neck system, and your proprioception, all of this information is combined and it's taken through nerves, which we'll say are represented by this arrow, afferent information, which basically goes to the brain, and it's integrated through central nervous system integration. And that allows us to function normally and properly, not have dizziness, not have vision problems, and allows all those systems to work together to produce just us working as normal, comfortable human beings. And when you get an issue with whether it's the neck or the vestibular system or the vision system, you'll notice that starts to produce problems. And this is often illustrated in the sense, you know, when somebody gets hit and you ask them, how many fingers am I holding up, right? You're really checking the visual system there. And it's a common sign of a concussion is having issues in any of these areas. We often check balance as well. We check their neck for neck pain and things like that. So we're going to jump into the vestibular system and kind of talk a little bit about how that's involved. So I like this diagram as well because it shows the same thing, but it more accurately kind of shows these arrows, which each of them leading toward the brain for that integration. And we're going to be talking about, we don't really know where the injury occurs in concussion. Like it could be the pathways to the brain, it could be the brain itself, but it's just a really good kind of depiction again of how all that's combined. So we'll quickly go over the vestibular system, and this is your vestibular apparatus. So this is basically just in your ear. It's about a dime-sized vestibular structure. And essentially what it does is it measures rotation. So in this example, you'll see these swellings, and they measure whether you turn your head like left or right. So you can see this person on the right here is turning around. And what's happening is as they turn, the fluid inside those canals turns in the opposite direction. So if you look at the second diagram just down here labeled C, you get this movement of fluid which moves the cupula, which is this mass-like structure. That of course moves the hair cells, that stimulates the nerve, and then you get that information going back to the brain and other areas where it all gets coordinated. So if you have that information coming from here, and then it's going to the spinal cord, which Jeremy already talked about, can get a bit of shearing, and he said that's where the vestibular system is housed. So you basically get that information going to the vestibular nucleus, and then it goes to the eyes, and that's how your eye and head coordinate. So in this particular example, you have left head rotation, and what it's doing is it's making sure the eyes, even when your head moves to the left, they can stay locked into a target in front of them. So you can imagine if somebody has a vestibular problem, like a nerve issue, or they've had a concussion and they're trying to look at something, or they're walking down the street and their head is moving a little bit, but their eyes can't stay on target, this is going to be able to produce dizziness for them and really kind of muck things up, give them a lot of anxiety about what's happening. And they're going to be thinking, you know, oh, wow, this head hit really damaged my brain and stuff like that. So part of our role is going to be educating people on this stuff and letting them know it's fine. We just have to rework the system and get it better. So also, you have other centers where the vestibular information is going. So if you guys can see here.
Oh, I think Alex just froze. That's not a good thing. He's the host. Okay, you're back.
Okay, sorry about that.
You froze there for a sec. So just go back maybe 10 seconds.
10 seconds. Okay, so what I was saying with this particular picture is just that essentially you basically have this information going through various centers through the brain. And as Jeremy said, these nerves can get stretched out and they can get irritated. And then so it's really important to regain that function and to train it. And that's what we do. And this is just another depiction of all the different connections, where the information is going from the vestibular apparatus. And if there's problems there, you're going to feel a lot of dizziness and some issues. The next one we'll get into is vision. Are we still okay, Jer?
Yep.
Okay. So often you'll get light reflecting off of different objects, going into the eye, through the optic nerve, into the optic chiasm, and then it's relayed through a bunch of different nuclei to the back of the brain, where it's processed in the primary visual cortex. So again, as Jeremy was describing with his jello analogy, all of that stuff jiggling around, getting stretched, having an electrical storm, these areas aren't going to function well. And in some cases, they don't recover that well, and they need to be trained back to health. And again, that's where we will focus on things. So the big question for you guys would probably be, how do we test this stuff? So it's really important, and we're really lucky at the sports clinic because we have various therapists who are actually both concussion and vestibular trained at a very high level. So we can basically do both at the same time. I actually started doing concussion therapy because I was getting so many people referring to me, other physiotherapists, for vestibular rehab. So they didn't really know how to do that part of the therapy that was required, help with their dizziness. And so I was getting those patients, and then I was learning more and more about concussions. So some of the vestibular tests that we would do might be testing the vestibular ocular reflex, which essentially is if everyone hold out their thumb in front of them and they move their head side to side, you should be able to see your thumb fairly clearly. In a patient with a concussion, this might be very aggravating for them. It might cause a lot of dizziness and a lot of other issues. So that would be an example of one vestibular test that we do. Another one for vision would be we look at convergence. So we check a person's double vision. The same thing, if you hold your thumb out in front of you, you should see one thumb. Some people actually see two at that distance. But as you bring your thumb closer and closer towards your face, what you'll notice is that it should double up at about 5 centimeters in front of your face. So that would be an example of a vision test. If it's abnormal, there are ways that we can treat that. Accommodation is another one, and people with accommodation issues will usually describe blurry vision. So this would be if you cover one eye, have your thumb out in front of you, and you bring it closer and closer to you, your thumb will start to look blurry at about 10 centimeters, and that's considered normal. Now, some of my concussion patients, they will see this blurriness much earlier, and we want to do different exercises to train it, or at least in the early stages, somebody just had a concussion, we want to monitor it. The CCMI, they like to use the vestibular ocular motor screen, which is a great test. And basically what it does is it packages all the vestibular and vision tests as well, and you get scores, and it's basically a provocation test. So does this bring on symptoms? Does it bother you? And if it does, it's a good indication that we should really be looking at vision and vestibular testing. We also check balance with a variety of tests, which has been shown to be compromised after concussion as well. The good thing is that we can always retest these things to gauge your improvement, and that's what you should be doing if you're on any plan. So even if you do try some of the rehab stuff that we're suggesting, you'd always want to make sure you're improving, and if you weren't, then you really want to get in touch with a professional as well to check all that stuff out for you and let you know where it's actually coming from. Because you might think, oh, well, I'm looking at my finger, I'm moving my head back and forth, that's my vestibular system. Well, it still could be your vision and your neck, and that's the hard work that we do, is try to tease out exactly what it is. So for vision and vestibular rehab, as I mentioned, we do some training of vision and the head, vision and head work together. So basically coordinating your head and eye movements. So we call that VOR training, vestibular ocular training, where you're focusing on objects, moving the head back and forth, trying to improve your ability to do this at a very fast pace that reflects how often you move your head in real life. Like you constantly are moving your head and your eyes and you're focusing on different objects. If this stuff isn't working really well, then you're of course going to have problems in your everyday life. And you see improvements as patients get better, they start to find things less and less irritating, noticing that they can do more things like driving and all these other sorts of tasks that occur in everyday life. Another two would be accommodation and convergence, which we talked about, the double vision and the blurry vision, so we can train that. And then once patients are getting better at this, we might also do motion sensitivity training. So this might involve chair spins or quick turns, or something I like to call the dishwasher exercise, which is basically when patients complain to me that, oh, when I bend over to empty the dishwasher and put plates away, I get really dizzy. So there are exercises that mimic these activities, or basically functional activities that the patients have problem with. And we really try to focus on that. And of course, balance, the last one there. I'm going to touch quickly on the neck because Jeremy's going to go into this as well. But basically, again, just to show on the right side, you have a lot of proprioceptive muscles, joints, and skin, which give feedback to the system, and it's also integrated there as well. So this is the back of the neck, and this is filled with tons of muscles, and they're actually shown in the neck, the joints and the capsules and the muscles to have 80% more afferent input, so more input to the brain than the average muscle. So the average muscle would have 50%, whereas it has 80%. So a difference of 30% there. And you can see all these nerves carrying all this information back to the brain. Okay, so what it does in terms of containing proprioceptors, this would be like a standard proprioceptor in a muscle that gives the brain information about how long it is, how much it's moving. And if that information is disturbed due to a concussion or muscle dysfunction, as Jeremy's going to go into, basically we get this weird input into the brain. And when that's all integrated in the system back here, you're getting a mismatch. So you're going to have the vestibular system telling you one thing, the vision telling you one thing, and then all of a sudden the neck is telling you something way different, and that creates what we call conflict, and that can create a lot of the patient's dizziness as well. So, and this just shows basically the muscle spindle down here and how that information is carried to the cerebellum, which helps with posture and coordination, and then also to the thalamus and the cortex as well. So various areas where this could get disrupted. Okay, and the rehab will involve neck treatment, as I said, Jeremy's going to get into right next. And then again, we do integration exercises. So once we've worked on the neck and we've helped it improve the muscles, we try to integrate this with things, complex movements like walking in a supermarket where you have to turn your head constantly, as that might cause problems. And we also combine this with the vestib and vision exercises in different neck positions or with balance. And there's a cool test that you can do. I did actually create one at one point earlier on in my career, but I kind of don't use it quite as much. But you can get somebody with a laser headband on, and you can check if they are accurate with their eyes closed at knowing where they're pointing that laser. And if they're off a little bit, you can use that to retrain their proprioceptive sense. And I think that is all I had. Sorry for the speed and going through that there. I'm going to switch it back.
Guys, if you have any questions, throw them in the chat box. We'll probably just copy and paste them if we don't have time and get to them at another webinar, at a later one. That was heavy. Obviously, guys, if you didn't get all of that or you got some of it, then I would say just get this. Think about this. If you're looking at me, I'm in your screen. If I turn my head to the right and I still am looking at you, you see how I'm activating my neck to turn to the right? My inner ear, the fluids are being moved while I'm turning to the right, and my eyes are still looking at you. You see how they're interconnected and inseparable? If you understand that, you kind of understand what everything he just said without all the scientific stuff, right? I want you guys to write in the chat box, what percentage of concussions do you think lead to or are associated with a neck injury? Like what percentage of people that hit their head have a neck injury? Write that in the chat box. I'll let Alex take a look at that. Now, just to explain, as you guys you're trying to answer that one, it takes 4.5 G's of force to create a neck injury. It takes 70 to 120 G's of force for a concussion. So do the math. To get even a concussion, you need 70 to 120 G's of force to get that concussion. It only takes 4.5 to get a neck injury. So you could be basically 100% sure that there's going to be a neck injury associated to every single concussion out there, whether they have neck pain or not. Just naturally, your head's going to be either thrown back or contracting as you get pushed or bouncing back. There's going to be some type of injury. And so what happens with a neck injury, let's say I got hit this way and I was rotating this way. So my inferior oblique, one of the muscles that Alex just talked about, either it got stretched when I got hit this way or it was trying to rebound and push me back. So I got basically just a strain in this muscle, right? remember if I turn this, it's on this side. So if I turn to the right, my eyes are looking at the screen and my inner ear is activated. Now, if there is a strain in that inferior oblique, it's now miscommunicating to the inner ear and to the eyes where my head is in space, right? So it might think that I'm a little bit off to the right or to the left, and now there's a mismatch between the eyes, the ears, and the neck. So how does that feel if you're concussed and you have something like that? You'll feel dizzy. Now, it's not the same kind of dizzy that we talked about 2 weeks ago or 3 weeks ago. It was the BPPV webinar where the room is spinning. It's like you feel off, you feel dizzy, you feel lightheaded, especially when your head's turned, but it's just a feeling of off that is often explained as dizziness. And then the other feelings you'll have if you have a strain in a muscle like that is going to be, you'll have like something like fatigue, because the amount of, when you have a mismatch in your brain like that, in your neck and your inner ear, the amount of work it takes to get through a day, with the amount of tracking you do when you're in the car, you're looking out the window, looking at screens, the amount of work when you have a mismatch is just higher. So you just burn more energy. You're going to be fatigued all the time. And then the last thing is headaches. I'm going to explain that in a second, but when you have, a lot of people think that when they have a headache from a concussion, it's because their brain has been bruised, right? That's not the case. There's just no pain nerve endings in your brain. It might feel like your brain's bruised and that's what's causing the headache. It's actually from the neck injury, and those damaged muscles are giving you a sense of headache, because when the way it works is the theory is called convergence. So if I have part of my nerve supply from the trigeminal nerve is here. So where, let's call it the SCM or the upper traps, where they go in and meet in the spinal cord is at the same place as this. They end up meeting and they join and they go in the same area of the spinal cord, which creates confusion. So a neck injury here will often present as pain or a headache up here. That's where the headaches come from when you have a concussion. Same with a car accident. So I'm going to share my screen again. Oh, that nice picture again. Hold on. So this is the comparison. MTBI, this is concussion, mild traumatic brain injury. Whiplash associated disorder. So this is a neck injury, like a car accident. Your head just gets thrown around, no concussion. Look at the similarities and symptoms. They're like basically a mirror of each other. I think even like Sidney Crosby's thing, I could be wrong, but like it took forever to come back. It turned out, I think it was the conclusion, he had a neck injury that was missed, right? So they present so similar, and then the only ones that don't, like TMJ dysfunction, I even find that in concussion as well. Like they're virtually inseparable. So the neck portion of rehab is like completely essential. Another thing I want to show you guys is some of the referral patterns that are quite common. So splenius capitis is just a muscle in the back of the head. Some people who are listening may have headaches. It often presents with a referral right at the top of the head. That's just one of the muscles that often gets affected with this. Give me a sec, it's frozen here. Suboccipitals, these are the muscles that Alex just talked about. They're the ones that have a lot of proprioceptive, that they'll often cause dizziness. They cause a headache that's often around the ear or often kind of behind the eye. And that's a common one as well. Another one is SCM, probably the most forgotten and undertreated muscles. Is the muscle right here, the one that you can see stick out. So that one refers sort of the top of the eye and sometimes to the back here. And the last one I want to show you guys is the upper traps. Who doesn't have tight upper traps, being that muscle at the top here that refers as a kind of a question mark around the ear. So when we have all those things, I'm going to unshare this. Hold on. Well, what do we do about it as a physiotherapist? Well, this is kind of our wheelhouse. This is where we're most comfortable. Like this has always been, this is what we're trained to do. So it's either going to be like soft tissue work on the muscles, but first we got to find, it's not like a shotgun approach. You'd have to come in, I'd have to look at your range, and then I'd have to palpate with my hands to see what are the muscles that are affected. You don't just go and treat them all. You got to find which ones. I mentioned 4, there's way more than that. Those are just some common ones that I wanted to mention. So palpation, I look at your range of motion, and then it ends up being soft tissue work. And then I find acupuncture really good to defacilitate a muscle. That means if a muscle has been injured, it often becomes tight and stays tight. And acupuncture is very helpful at getting that muscle to calm down and come back to norm. The other thing is joint mobilizations and or manipulations. Now, I don't do neck adjustments anywhere near the beginning. And to be honest, I don't do them that often anyways, a joint mobilization. So if a joint becomes stuck because you moved really quick like that and it's jammed up, you got to unjam it. That can also cause referrals and headaches as well. And then like some of the softer things that are super important is going back to the basics and talking about like posture, like the vestibular spinal tract is one of those tracts that's responsible for extension and anti-gravity muscles. It's not uncommon to get concussed and just see people just slouch more than ever. So that's why sometimes I'll give people extensor exercise as well. But education on posture, and then I think breathing goes a long way, especially in that early phase. Remember I talked about how there's like energy crisis where people are just fatigued. Just going back to the basics and rebalancing the parasympathetic and sympathetic nervous system by just doing diaphragmatic breathing. The other thing that diaphragmatic breathing or belly breathing that's super helpful with is if you breathe through your tummy, which I just did a YouTube video for that, and I'll post that at some point. Then you're using the muscle that cuts you in half, that's attached to your lower 6 ribs, instead of all these muscles around here that pull your thoracic cage towards your head. Now I'm activating my SCM, you're just facilitating them more. So some of it is just education on gaining better habits so that the rehab process is a little bit smoother. And then really brief, we have about 6 minutes left. I just want to talk a little bit about a case that I'm currently working with actually through this platform, through virtual care. I was seeing him in clinic for a while before this all started. And I was, he had a balance issue mainly. Otherwise, he's doing pretty good. He just feels exactly what I said. He feels off. He feels dizzy, but not spinning. He just feels like he's off balance. So I've been focusing a lot on like the visual stuff, the inner ear stuff, because it's balance. I'm like, that's a no-brainer. And I just wasn't doing much work on the neck, to be quite honest. And so I was like, okay, well now I can't, we're on this platform, I can't do it in person. So I just started giving him neck stretches and using a lacrosse ball and putting it at the base of his skull. His problem is more when he's looking to one side, so I'm targeting the side. So during the session, I'm guiding him where to put the ball, and he's doing double chins, and he's starting to release the back of his neck. After like 1 week of doing that, so his single leg stance, his ability to stand on one leg was 4 seconds, and it was stuck there for like a month. It was crazy. No matter how much we stimulated, he was over facilitated, so the muscles was tight. So what I was doing wasn't helping him. So we took a step back, we went back to soft tissue work in the neck. He's doing it by himself. I'm guiding him with it. He's doing like double chins and all that stuff. By the way, don't go home and use that as your only treatment strategy. If you had trauma to your head and your neck got thrown around, you want to rule out that there's no skull fractures, neck fractures, or blood flow issues. You know what I mean? So you don't go and do this. But anyway, so he's been doing this stuff. I got him now almost on a consistent basis doing single leg stance for 30 seconds. And how quickly did that change happen? 1 week. It was I couldn't believe it. I was like, oh my God. I felt like I'm the idiot. But it was kind of that light that went off to be like, I need to take a step back, go back to the basics, find a good manual therapist who can do some good soft tissue work. And then once that's freed up, now it makes sense to go and stimulate the inner ear, stimulate the eyes, put it all together with these exercises. Does that make sense? Alex, anything else you want to add, or a case or anything? You got 4 minutes.
Yeah, I think what you said there, just putting it all together, right? Like working on the systems and then integrating them all together. And that's what I was trying to touch on just in my presentation there. It's all about putting the vestibular system, the vision system, getting it all, giving good information to the brain. There's no more mismatch, and then the people will function a whole lot better. It's interesting because I've also had those cases where it doesn't seem to be coming from the neck, where it's just vestibular. So it can go both ways. And that's why it's important to really be with somebody who's looking at all of the different causes. Like I've had patients where they had a concussion and their biggest thing was just constant dizziness. And we primarily did vestibular rehab exercises because the neck was moving absolutely fine. And they got better as well. And that was the biggest part of their rehab. I've also had clients that are primarily vision, and their vision was just so obviously disrupted that I really had to send them to a neuro-ophthalmologist for more intensive care, because as they have more insight into that. So sometimes we have to collaborate with other healthcare professionals.
If you guys are watching this either today or somewhere else in the world at another time, I would just strongly encourage you, seek help. I think if you can find a CCMI certified practitioner, you know, at least they're going to have good protocols and things in place to help you out. Otherwise, we have about 2 minutes left, so we can go to the chat box and see if we can tackle this. If it gets cut at the 1 minute mark, we'll cut it off. But isn't acupuncture in the neck delicate with all the nerves jammed in there? Usually for the neck, I'll use a smaller, skinnier needle. Keep in mind, like the size of an acupuncture needle is probably 10 times smaller than what you would get for an injection in your shoulder or to do blood work, right? So if you go in slowly, very slowly, no, it's actually fine. And I find it to be, I'll be honest, I acupuncture my own neck once in a while if I don't have access to someone, and it provides like immediate relief. And I won't get in exactly what the scientific reason for it right now, because we only have a minute, but it's a good tool. Is it the only tool? No, you could totally just, do hands-on soft tissue work, massage therapy, all those things work as well. Lacrosse balls, there's so many ways to do it and be effective.
Definitely, I would agree with that.
So there's a lot more questions, but we're going to be cut off. So I'm going to take the last minute to say a huge thank you for the people that followed along this little journey of 12 webinars. I kind of said at one point I was going to do a few more, and I am not going to follow through with that, because the amount of work that was associated to get everyone involved in place and to get ready for these things was awesome, and I had a great time doing it. But I do want to provide you guys with some cool YouTube content that's going to be specific to, like, okay, how do you use a lacrosse ball to release your traps? How do you diaphragm breathe? I got 50 ideas, and I want to start working on that. For that reason, we're going to pick up where we left off with webinars going forward once we're back in clinic. The 12 webinars, or at least 10 of them, that are on YouTube, you guys can go to my YouTube page, subscribe, and check them out. We're also going to be feeding them to our client base once a month starting in June. So every month you'll get a webinar, and you guys can watch it then and rewatch it or whatever. So guys, thanks for joining. It's time for me to go celebrate my birthday.
Jeremy, one question.
Yeah.
Is the clinic reopening?
Guys, stay tuned. We're going to do our best to let you guys know. We don't know yet. We don't know when, but trust me, I want to know. And we're going to get cut off any second. We will do our best to let everyone know.
Bye, everyone.